Welcome to the Code of Life. I'm Randy Neal. In this episode, we highlight a unique session from GenomeBC's 2021 annual forum called COVID-19, a moment of importance for genomics. This is an episode you will not forget. It goes far beyond this pandemic to how COVID has shown with deadly results the stark inequities around the world. It's a panel discussion that includes a very familiar face, BC's Public Health Officer, Dr. Bonnie Henry, as well as Stephen Hoffman, a professor of epidemiology at McMaster University, as well as global health and population at Harvard University. The panel is moderated by Tony Brooks, CFO and Vice President, Entrepreneurship and Commercialization at GenomeBC. But the discussion starts with Michael Ryan. He's an Irish epidemiologist and former trauma surgeon and the executive director of the World Health Organization's Health Emergencies Program, leading the team responsible for the international containment and treatment of COVID-19. Dr. Ryan begins with a sobering update about COVID-19, but also a dire warning. This pandemic must be our wake-up call for the future of healthcare around the world.
Good morning. It's not great news I have to report to you regarding the pandemic right now. While the perceptions may be in certain countries that we're rounding the turn and getting towards the end of this, the reality is that for the second successive week, the number of cases remains at a global and historic high in this pandemic. We've had over 93,000 deaths in the last week. You've all seen the images from South Asia, particularly from India, and the huge number of cases there. But there are other countries experiencing maybe not quite as intense transmission, but very similar problems with continued community transmission, with health systems under huge pressure, with variants taking on a higher and higher proportion of cases. So we are still very much in the acute phase of this pandemic. And we are seeing the great value that vaccines are starting to have in reducing morbidity and mortality, and even in reducing and driving down transmission. But at the same time, while we see the hope in that, we're also seeing the tragedy in how those commodities and how those life-saving interventions are being distributed in a highly inequitous and unfair manner, which really leaves us in a position where we have frontline health workers and highly vulnerable people in many countries not protected, while we consider vaccinating full-scale populations in others. So we are at a moment of a testing moment for the world in terms of whether we can see our way to being as equitable as we say in our words and closing the gap between the laudable rhetoric and the actual reality of this pandemic for many, many people, particularly those in the global south. Having said that, I think this pandemic has brought out the best in many. It has brought out the best in our frontline health workers, the best in our community leaders. And I don't just mean frontline health workers, I mean frontline workers in general, those who've kept society going, kept education going online as it may have been, those who've kept services moving. They've been incredible. And our communities have really stood up globally to this very, very testing time. And they've been good to that test. Communities have tolerated an awful lot. They've seen their social, their economic, their educational lives disrupted. We've seen delays in necessary medical treatment. We've seen delays in educational attainment. Many, many sacrifices that communities have made in order for this pandemic to be brought under control. And those sacrifices have borne fruit. And I think our society is seeing again the value of health, the value of prevention, the value of access to health services. We've unfortunately, though, seen as well that many of them deaths and much of the severe disease, the seeds for that was set many years ago with poorly managed health conditions, with lack of access to healthcare. I've said it many times, I think this pandemic has ripped the bandages away from some very old wounds in our society, wounds of equity and access exclusion. People in many countries, and it doesn't matter which country, rich or poor, those who've been excluded in society from access to preventive care, access to nutrition, access to mental health, access to so many other things that have now become exposed brutally in this pandemic. And sad and all, and tragic and all as that is, I think it's a wake-up call for us, not just in pandemic preparedness. And there is a need, and we do, and I'd love to have a conversation about how we can prepare better for the future. But it's not just about pandemic preparedness. It's about the way our society treats health. It's the way our society treats its most vulnerable, its most excluded, because this pandemic has clearly exposed those vulnerabilities. It's exposed those inequities, and this conversation can no longer be purely about health systems. It must look at wider societal values for the future. But right now, we're not finished with this pandemic, and it's certainly not finished with us. And we have to stay the course, and we have to fight and reduce and mitigate the impact of this disease, and continue in as fast a means as possible to distribute vaccines to those who most need them around the world. I'm actually it's almost a moment of despair and a moment of great hope at the same time, Tony. I'm in despair for what's happening in places like India and Brazil. And I have huge hopes that if we can accelerate vaccine distribution and we can deal with some of these fundamental issues, we can emerge from the worst of this pandemic. And we can begin to learn the lessons for the future. For me, there are many lessons to learn from this in terms of resilience, in terms of flexibility and our ability to be prepared for the next one. The lesson I've learned is, and I've said this before this pandemic really began, and Bonnie, you've heard me say this many times, I was always concerned that the least resilience was in the north and the most resilience was in the south in terms of systems. Our complex, highly technological health systems are been inflexible. We've run our health systems on fumes. We've seen health as a cost. We have, previous to the pandemic, 95% occupancy in our hospital beds, and then we expect them to surge. How do you surge health staff that are already understaffed? How do you surge more beds when those beds are already full? Our health systems are not adaptive, they're not dynamic, and they're not flexible, and they cannot absorb the punch of a major emergency without serious organization and reorganization. I think we've learned the lesson I said previously about inequity in health will come back and bite you in a crisis, and it has in this case. But I think for me, the fundamental lesson I think I've learned, and one we need to listen to as we prepare for the next, is epidemics begin and end in communities. And I think we've forgotten that. And we need to refocus on how we look at public health, primary healthcare, health services, and health protection as starting in a community from the bottom up. And I hope as we emerge from this pandemic, I was likening it the other day in a conversation to building a suspension bridge. You have to build from both sides and meet in the middle. And I think as we go forward in pandemic preparedness, yes, we will have big global initiatives and they will be needed. We need better global data. We need better development of research and innovation. We need better global financing. All of those global things will be needed. But we're also going to need to build from the bottom up, from communities, with community-based interventions, more community engagement, more community agency and ownership in defining priorities for the future. So I think there's an awful lot to consider going forward. And I think we should have that conversation, and we will begin to have that conversation at the World Health Assembly in a few weeks' time. And we have a number of reports coming through that will look at both the current pandemic response and look at the issues for the future. We just launched a major initiative today with Angela Merkel and Minister Spahn in Germany on a WHO hub in Berlin for data analytics and others, and recognizing the huge role that Canada has played in epidemic intelligence over the years with GFIN and other things. Looking forward to collaboration with Health Canada and with Canadian institutions on that. So we will need to build those initiatives for the future. But I do hope that as we build those technological solutions to our problems, we don't forget that ultimately it is communities that are at the heart of our system, and we need to learn to serve them better. And especially in managing the new world of infodemics and information and trust and mistrust, I think there's been trust lost in many circumstances between governments and the communities that they serve. Some have done very well. Congratulations, Bonnie and Steve and others in Canada. I think you've done an outstanding job in keeping those lines of communication open with communities. And I think Tony was on before. He's been brilliant in keeping those channels open in an open, honest, scientifically based exchange with our communities. But that has not been the case in every country. And deep distrust and misinformation has driven much of this pandemic response, including the political manipulation and distortion of information. And that has been deeply destructive and something we need to address as we go forward as a society. So with that, I'll finish my remarks there. I'm looking forward to a good Q&A. Thanks, Tony.
Thanks, Mike. I'd like to now ask Stephen to comment.
A big thanks to GenomeBC for bringing together this event and for inviting me to be part of it. It's really quite an honor to be speaking, sandwiched between two heroes, Dr. Henry, Dr. Ryan. Looking very much forward to the conversation that happens after these initial remarks. For that, what I'm going to do is I'm going to provide a bit of a national perspective from the Canadian context. I'm going to do that. It's a bit different for me. I'm a global health researcher myself, so usually that's the angle I would take. I'm going to do the national perspective, though, both because I was asked to do that, but also because of my role at the Canadian Institutes of Health Research, leading the Institute of Population Public Health. And specifically from a national perspective, I'm going to take this opportunity to emphasize the important role that science is playing and needs to play in all of this, and the way that we need to be thinking about the role that science plays as part of a strengthened public health system or systems across Canada in the future. And so what's needed for this pandemic, or what was needed for this pandemic, what is needed for this pandemic, what's needed next time? I'm going to highlight just three things, and I'll do it very briefly. The first is a strong foundation of science. The second is the ability to rapidly respond. And the third is the ability to engage the full range of the research enterprise to go in the same direction. So first, in terms of that foundation, it's clear that science, and all that science has been able to do, and the way that it's been mobilized by our public health heroes, is what is going to get us out of this pandemic. It's clear that our understanding of this virus, our ability to develop a vaccine vaccines as fast as we did, our ability to adapt and deploy clinical protocols and such, it's very much all dependent on science. To have a strong, to be able to mobilize science in a national context, as we've been doing in Canada, it depends on a strong foundation. Sometimes what that means is we need to be making investments based on investigator-driven priorities. And by that, what I mean is it's impossible to know all the areas of science that are going to be needed. Therefore, that explains why most of the resources that the Canadian Institutes of Health Research, for example, invest are very much focused on investigators putting forward their best priorities, their best ideas, and then being funded as a result of peer review committees, also staffed by leading investigators from around the country. But there is also a need then to be thinking about taking stock of what scientific expertise is there in our country. What we've seen during this pandemic is that the same expertise is desperately needed all at the same time in each country around the world. And so it has brought to the fore some critical gaps in expertise that is available in Canada. And so in the future, a strong foundation means that we're taking stock of what are future scientific needs for the full range of emergencies, and in taking concerted efforts to ensure those needs are filled. Second, in terms of rapid response, government funding agencies have not traditionally been designed in order to be funding research on the timelines that a pandemic requires. We at CHR have done some work in the past, for example, in response to both the Zika pandemic as well as West Africa, and then in the DRC, we mounted rapid research responses whereby Canadian researchers were able to partner with researchers around the world to tackle those issues. But it was still a matter of, well, usually it might take a year for us to develop a funding opportunity, open it up, accepting applications, peer review it, get the check out the door. We were able in those instances to do it in as short as a couple of months. But a couple of months is not fast enough, right? When you think of this pandemic. And so I am really proud, actually, at CIHR, we mounted from what we can tell, is the fastest research response from any government in the world. We activated our emergency response mechanism on January 20th, 2020. So before this pandemic had gone international, before there was a single case in Canada, we'd already activated millions of dollars of research, knowing that this was on a trajectory that was going to a bad place. That being said, we need to do better. Everyone needs to do better. And what that requires is thinking about redesigning these kind of processes to make sure that once there's threats of whatever kind, immediately there's resources available for researchers to do their thing and ensure that we have knowledge to inform our response. And then the last thing I'll just briefly mention is how do we engage the full range of researchers in this process? I think this pandemic, of course, it was a pandemic of a virus, but it's also been a pandemic of socioeconomic consequences. It's been a pandemic of inequities, including in Canada. Of course, we're a very privileged country, one of the richest in the world. Even in our country, there are deep inequities that have been revealed during this pandemic and brought to the public fore, and everyone agreeing would be unacceptable. And so for that, though, it means that if this isn't just a pandemic of a virus, it's also a pandemic of socioeconomic consequences, of inequities. It means we need to figure out mechanisms to engage the full range of researchers in this process. And I'll end just by highlighting one example, one recent example that might be particular relevance to this forum is around variants of concern. I think that because of the advances over the last decades in genomics research, we've been able to sequence and identify variants of concern in this process, and then being able to inform efforts to address them in the broader pandemic. But what's important is it's not enough, of course, just to identify a variant. We need to figure out, okay, is it of concern? And then even if we know, yes, it's a variant of concern, there's still so much research that's needed around, okay, what do we do about that in a clinical context? How do we monitor spread? What does it mean from our public health programs perspective? What is that? What are the downstream consequences for our strategies around schools and businesses? How do we communicate the variants of concern and issues around it? All of which on one hand are things, yes, we have to do. Those are all researchable questions that we need to ensure we can be able to do in order to map the most effective response possible. I'll leave it there, and just a big thanks, and it's a big honor to be part of this panel.
Thanks, Stephen. Bonnie, would you like to add some perspectives from a more regional, provincial point of view?
Thanks very much, and I'm really grateful to be here with you today. And I want to start by acknowledging that I'm speaking to you today from the traditional and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh First Nations here in Vancouver right now. And I'm just very grateful for the keepers of this land to be able to speak to you, bearing their wisdom in mind. And my job, our job, is to bring people along with the science. And I agree with Steve and Michael. You know, this pandemic has exposed a lot of inequity. It's exposed a lot of the frailty of our system. And my job in this role is to bring people along without being paralyzed by fear or without lashing out in anger, which are reactions that we see when things are uncertain and changing. And we have seen very much in this pandemic science in action, and how to translate that so that people understand that making a change and making a difference and how we modify what we're doing is based on changing data and information, where we know that that type of uncertainty and things that I have learning is that nuance creates fear and anxiety in a lot of people. So part of my job is translating the science in action. And I've said many times we're in this same storm globally, but we are not all in the same boat, and we need to recognize that. But when we have science pulled together, combined with purpose, collaboration, and compassion, that is how we can lead to some of the important advances that we have seen through this pandemic. And I absolutely believe that it is that combination that has led to the miracles that we have seen. And, you know, I'm not somebody who's driven to hyperbole, but the fact that we have vaccines that are effective and work in the oldest members of our society and our seniors and elders who have been so traumatized by this virus and devastated by this virus, it is nothing short of a miracle. And it is because we have had that collaboration globally and pulling the science and the brains together to pick up all of those pieces of basic research that had been done in many different places and had been supported, though many scientists would say had been languishing for many, many years. But pulling all those pieces together and being able to come up with something that is going to get us through this pandemic. Never before have we been able to watch the genetic mutations in almost real time, to use whole genome sequencing to understand the progression of this pandemic. And it's something we have been doing in Canada, here in British Columbia. We were using whole genome sequencing from the very beginning, and it really helped us understand how we are connected to the rest of the world. We are connected to China when we could tell that sequences were coming in from China. We were connected to Iran when we first had a case here in British Columbia, when we didn't even know that this virus had been infecting people in that country. And we are connected to our neighbors to the south, and Washington State was one of the biggest influxes of cases that we started to see in the beginning. But we need to be very careful. Viruses mutate. That's how they work. And we know that that's a natural phenomenon. And we can just watch this natural process unfolding by using these scientific techniques of things like whole genome sequencing before our eyes. But we have to not lose sight of the fact that these are not just variants of concern. They're not some aliens that we can put up a shield and protect us from. These are people. And these strains of the virus are infecting people, and there are people. There are family, there are community members, and to recognize that the virus is passed on from those we are closest to. We bring it into our community through our actions, through our activities. We pass it on to those that we are closest to. And we must be careful never to dehumanize our response by focusing just on a sequence or a variant or the virus itself. We knew that variants would arise. We knew that the RNA viruses, they survive by getting some survival advantage by either replicating more quickly or being able to be more transmissible. And of course, our worry is that we need to continue to watch how the virus is changing in people so that we can tell if our vaccines are still going to be effective. But we would, these viruses travel with us as we move in our world, in our community, and in our family. And from my perspective, making the decisions about what we must do to try and understand and combat these new viruses and these new strains is really about people again. So data, models, all of that important science that we're seeing come out of researchers across this country and around the world, it never tells us what to do. They give us the ideas of which are the factors or the variables that have the most impact, but it all has to be coached in the world that we live in around people, around value, around judgments, around trust and acceptability. And so I know many of the scientists that I work with very closely here in BC, across the country, they say, well, I told you this was going to happen. So all you needed to do was, stop the variants, without understanding the impact of the measures that we would have to put in place. We can't just stop this virus without stopping people. And so my concern and what we have been working on is how do we combine those important scientific and data pieces with the measures that we can put in to support our communities. We know that this pandemic, as both Michael and Stephen have indicated, has not affected people equally. Many people have suffered more, no more so than our Indigenous communities, than racialized populations, and our youth. We know that they have been impacted and have had the least amount of control on what's happening in the world around them. Lockdowns are crude tools, and they have lasting harms. And one of the things that we need to channel, and we've been trying to channel here in British Columbia, and I know across Canada, is documenting the harms of the measures that we've put in place, or the impacts, whether it's positive or negative. And there have been some positive impacts of the measures we've put in place. But understanding the mental, emotional, and physical health, both from protecting people from the virus, making sure our health systems aren't overwhelmed so that we can get the care we need, both for COVID, but also for all the other health health issues we have, but understanding as well the impact of the measures that we're putting in place to try and stop the virus, understanding who is suffering more. And it comes down to influencing human behavior, influencing us to understand that we can't have those social gatherings that we so need in our lives right now, to help use the data, to put it in the context that supports people to do what we need them to do, which is staying small, which is not traveling, wearing masks when we're around other people, staying out of those indoor, non-ventilated area, where the science changes to be able to bring people along us. And that comes with our ability to communicate the science that we're seeing. And we can change that we know leads to anxiety, leads to alarm or fear. We need to change that through our communications to adaptability and resilience, to putting in place those the communications and the connecting with people with kindness, with compassion, and with understanding. And that is science in action in my mind. And that is what we have learned through this pandemic that we need to take forward with us. And I'll stop there as well.
Thank you very much, Bonnie. Some great comments, and lots of good subjects to dig into. So I'd like to just take it back to some comments Mike said about, and in fact all the panelists said about exposing the inequities in our societies, in our communities, and I guess this is kind of the question I have is, there is no doubt these things all exist, but what tangible steps can we take to try and address that? How do we, I mean, as you indicated, at a community level, you can do it, but how do you perhaps look at doing this on a countrywide level or even globally? For us to get us thinking about not only are they people who are underprivileged, if you like, in our own community, but there are people on another side of the planet who are equally important because they're all human beings. So perhaps you would like to comment on that. Maybe start with Mike.
Well, thanks, Tony. I think we need to look at this in sort of two timelines. I mean, one is what we do about equity in health and healthcare in general, and really to speak about universal health coverage and the fact that every human being should have access to prevention and curative services that are essential to life and don't cause economic hardship to individuals. And that's built into WHO's constitution. It's a fundamental underpinning of the Sustainable Development Goals of the United Nations system. So the commitment is there. The decision has been made to try and achieve those goals. And within that, those health goals are very, very, very important. So the destination has been decided, has been agreed. The problem is how to get there, and how to get there without a fundamental shift in the way health is seen within governments. And now as a center of cost, not as a center of investment. The health is seen as an expenditure. It's seen as a pure expenditure. It's not seen as a capital investment in the welfare and well-being of society, as a productive concept within government. It's seen as an expenditure, an expense. It's a waste of money in political sense from that point of view, unless, of course, it's a few months before the election, and then you can promise away to get your votes. That's the reality. Health has become a political football. It's a means, it's a device, and we need to change that. Now, I'm preaching the converted. I have to say that Canada, in general, has had a very evolved attitude to healthcare and universal health coverage in the system you have in Canada compared to many other developed countries is remarkable. Now, I'm sure if I was sitting there with you on the Canadian side of this discussion, you could probably have a very good discussion of what's right and what's wrong in the Canadian system. But what those of us who look from the outside in see that Canada's basic premise is one of universal health coverage and access to healthcare. However imperfect it may be seen from inside the glass house, we certainly shouldn't be throwing any stones from our side. And certainly Canada is a leader in this issue of the right to healthcare and what that means. However, having said that, if we look at the current situation of what we can do practically, look, if you live in a low-income country, you're 86 times less likely to be getting a vaccine today than if you live in a high-income country. We're not doing too bad. That's come down from a likelihood of 200 times. A few weeks ago, you were 200 times less likely to get a vaccine if you're in a developing country versus a developed country. That's the reality. Nearly a third of high-income countries have now nominally vaccinated probably more than 20% of their population. If you go to low-income countries, nobody has achieved that basic number. And that 20% is a rough calculation of health workers plus the vulnerable, the most people most likely to die. And if you take the low and middle-income countries together, it's only reached less than 2%. So if you live in a low middle-income country, the likelihood is the vast majority of your most vulnerable and the vast majority of those people most needing vaccination are not covered today. Whereas if you go to high-income countries, increasingly every day, a new high-income country reaches that golden number. That is the essence. They're the metrics of inequality that persist today. And the only way that is going to change in the next number of months is if, number one, the COVAX facility is funded properly. Number two, if countries start to share doses of vaccine. And number three, if we get a waivering of TRIPS agreement to allow the proper transfer of technology to boost production. That's probably not going to happen in weeks, but there's a whole series of things that are practically set out. And Dr. Tedros and others have laid out that roadmap for what actually is needed. And we thank the government of Canada for their leadership on this. Canada has a huge capacity to influence as a neutral country, as a champion of health and primary health care, as a champion of universal health coverage, champion of inequity, to speak up on this and to lead from the front. Because the reality is that it won't change in the next number of months unless it changes. If we don't change it, it won't change. That's the fact. It is locked in. The inequity is currently locked into the system and it needs to be unlocked. Someone needs to break this door down and change the game, because the current situation is unacceptable. It's a tragedy. It's an abomination to me to see this. That's not to say that people shouldn't protect their own population. So at the end of the day, the primary job of any government is to protect its own population. And we agree. And everyone should have the right to do that. But within that, we need to look at what population. You spoke, Roddy, about community. What is community? We have a local community. We have our state community, we have national, and we have a global community. We are one people. We are one community. And can we stand idly by while perfectly healthy and low-risk people are being vaccinated, while hugely vulnerable people in the world have no prospect of getting a vaccine in the next 6 months? And we see the disease intensifying in its transmission. If we were at the tail end of this pandemic with low rates of infection around there, but we have countries experiencing huge epidemics with very low vaccine coverage. This is a major problem. So two things. One, we need to work on the vaccine equity issue right now. And two, we need to recommit ourselves to more equitable health systems going forward. And that's a bigger nut to crack, but I think we need to first deal with, if we can demonstrate a better performance on vaccine equity, I think all is possible after that. This is a real test. What do we mean by universal health coverage? What do we mean about the right to health? Because if there ever was a time to demonstrate the basic right to health and the basic right to health access, then this is it. And the way we can demonstrate that is by doing a better job at distributing this vital and life-saving product, which is called a COVID vaccine.
Thanks, Mike. Bonnie, would you like to comment? Any tangible steps that we could take?
You know, I think there's speaking from a local level, because I agree with Mike entirely that, vaccine is a way to show that we've learned something about how to protect our global community. But, the things that I reflect on that we've learned here in BC and across Canada is that the people that we rely on day to day, who is our essential workforce, for example, are hidden until there is a crisis. And, we were looking at, it's the people that work in our grocery stores, that transport our food products, that work in our poultry and meat processing plants. These are essential workers, but they're also people who don't have the agency to stay home if they're not feeling well. So some of the basic things that we have learned over this pandemic has really exposed that those people who are most vulnerable are most marginalized in many ways. And things that we can do that make a difference are having things like ensuring that people have the ability to stay home when they're sick. So sick leave, something that is quite basic, but is not in place in most provinces in this country. Some of the things that I hear that are, we rely on things like internet and being able to access things in ways that we are now appreciating are so important. We still don't have access to basic internet and broadband in much of the north of this country and in this province. So simple infrastructure things that can make a difference in people's lives across the board. And when we had to suspend schools for a period of time where we were trying to understand, it was the children who did not have those accesses, didn't have that support, that fell the farthest behind. And we need to make sure that we have those things in place to bring those children up and to raise them up in a way that makes a difference going forward. And it is how we look at our most marginalized populations. We have immunized in British Columbia temporary farm workers because we know how important they are, even though they come from Guatemala and Mexico. But they're part of our essential needs in this country. We've immunized people who are in our correctional facilities, who live in poverty, who live in our downtown east side. We have made it a focus to ensure that we are protecting First Nations and Indigenous populations in this province and across the country, because we know that they are most at risk of having adverse outcomes. And that is not, that's something that was controversial for many, many people. And I hope that we've shown that that makes a difference in a way of building up and reducing those massive gaps in inequity. And we're trying to do that with our immunization programs here, even in Canada, where we continue to recognize that wealthier people with agency are more likely to be immunized, even now. So we have to look at how we are managing our programs to try and privilege those who are least able to have that agency to get it themselves. So those are some of the things that come to mind for me from my perspective.
Thank you, Bonnie. Stephen.
I think whether societies have equity or inequities, it's the result of some hard choices that have been made, and there's consequences with these choices, and we see them playing out during this pandemic. I think what's clear is that those who there are people who benefit from not taking an equity first approach, for example. And I think what's really important then is highlighting that for most people, though, that's not the case. I think very often a lot of the problem is a choice to not hone in on what, and to decide that this is important, and then to better understand the problem, and then be able to make choices to be able to privilege interventions that will lead to better equity in the long term, and then help all of society in the process. One of the challenges we see, though, is around data. So I'm going to bring that science lens again. One of the things that likely mistakes that were made in different places around the world was around collecting data that wasn't disaggregated by various important variables. What that meant is that we had situations where in many parts of, well, different geographies, we didn't fully know who was getting COVID, where was it spreading, to what sort of populations, in which geographic areas, income, socioeconomic status, education. race, ethnicity, various factors that are actually really important for better understanding, to what extent is this pandemic affecting different people in different ways? And to what extent can we design strategies that are more likely to be effective? I think a lot of what we've had to do in various parts of the world, various parts of Canada, have been taking blunt approaches to trying to lower infectious burden overall, because we didn't necessarily have the precision of data in order to make more targeted efforts. And that, I think, is where the real opportunity lies, because at the beginning I mentioned like equity is a choice, and sometimes choosing equity means that one person, let's say, gets a vaccine, someone else doesn't. But actually, where the benefits align is that there's real equity dividends in the form of being able to, if we have an equity mindedness, it's about identifying different needs and identifying then different solutions to address those different needs. That could allow for unlocking a much more effective response and moving away from blunt tools that we've had to do because we haven't had that data, we haven't had that science around how do we better design more targeted interventions to serve the needs of communities. I think going forward, that I think is a place where we're going to learn a lot. So there's already so much attention in Canada about the state of our data infrastructure. Many Canadians, for example, have been very surprised that we haven't been able to track vaccine deployments in the ways that maybe some other countries have. People have been surprised when it's only later in this pandemic we were able to geographically show where are cases of COVID and where are they not, including some places in this country we still haven't been able to do that. And I think what this, in terms of equity, Canadians are, and people around the world are demanding more from us. And I think science and scientists, anyone involved in data, anyone involved in then making use of that data, as Dr. Henry said, integrating it with values and preferences and other considerations, are going to need to be part of a solution. Because without that data, without that science, without integrating that into decision making, it will be more difficult to act on equity.
Thanks, Stephen. I would just like to put one more question to Mike, because I understand he might be leaving us quite soon. And that is, you mentioned the complete inflexibility of health systems in the North, or inflexibility and resilience. Could you just maybe share if the WHO has any tactics as to how to go about changing governments' minds with respect to their approach of using this as a cost center and keeping costs down to a minimum? You know, obviously you have it in your mandate and on your sort of mission and vision, but what are the key things that you try to do when talking to governments about, let's put aside more money so that we have greater flexibility?
Yeah, no, it's a very good question, Tony, and maybe we obviously haven't made those arguments very well because obviously we weren't ready. I think we have to shift the narrative towards one around protection and security and away from just one of service delivery, and ensure that the health and public health systems are not just seen as service delivery, that they're seen as actually providing national security. Because when you talk about national security in that sense, nobody questions why you have an army. Nobody questions that. Does an army have to fight a war every year in order to justify its existence? No, it doesn't. It's seen as a strategic investment in the security and the safety of the population that is governed. It's seen as a profound responsibility of government to protect citizens from foreign invaders. That is the role. And nobody, well, people may question it, but nobody wants to fight a war, but everyone needs to be ready to be able to defend the state and defend the country's interests. So that's a principle. I'm not so sure I agree with military spending at all, but there's at least a principle behind it that you could look to. I think equally so. I remember talking to a bunch of teenagers at one point, and they couldn't understand why people weren't investing in this. And I said, yeah, it's a bit the way we treat health. You know, you buy your car insurance every year, and when you don't have a car accident, you don't go back at the end of the year and say, can I have the money back? I didn't have an accident. You know, You pay your insurance because you know at some point in the future you may have an accident. You don't know if it's this year or next year, and you pay that every year. You pay your house insurance every year. You pay your car insurance. You pay your life insurance. You invest against a risk that may never arise. But you want to mitigate that risk by spreading the cost of that across as many people, as many societies, as many years as you can. So that then when the inevitable or the unwanted happens, the resources are there to respond. The resources are there that are needed. That is the principle that we use in society all the time. We need to start seeing investing in health and preparedness as insurance against the future. It's a check we pay for the security of our children. We do that all the time. This is not alien to human culture. You were talking about aliens earlier, Bonnie. It's not. In fact, this is the natural way. We put things away for a rainy day. My grandmother used to always talk about putting stuff away for a rainy day. And I remember at one point there was a very bad financial crisis in our family, and I remember my mum turning around and saying, "You know what? This is the rainy day." You know, and that's where I think we need to see health as a precious investment in the security and safety of our citizens. It should deliver ongoing prevention and curative services, and it must be ready strategically to deal with the impact of a crisis. That has to be the third pillar. And it's not currently built into the system. We have to make that argument, because clearly we're not making the argument successfully, because it hasn't happened and it isn't happening. Maybe this pandemic is the final wake-up call for us all to get that job done. Over to you.
Can I build on that? Because I absolutely agree with you, and these are things that we've been saying in the public health world, but even in public health and in healthcare, but in public health, any sort of, we're one layer thin, right? There's no redundancy, there's no backup, there's no, we talk about IT systems not having the ability to collect certain data and share it. And it's because we've been whittled away, so we're very thin. And if we look at a bank, to not have a backup IT system for all of their accounts would be seen as criminal, essentially. But if we have backups or redundancy in public health, it's considered waste. And we don't look at our healthcare system as being robust and needing to be robust. There are many, many things that we could do with public health people who have great abilities to do everything from immunize to safe water to, all of the things that we do in public health, but we're one layer thin. And we've been whittled away over the years, and it's very, very challenging. And then when you have a pandemic and you're all of a sudden depending on public health for contact tracing, for finding people, for managing these outbreaks. And we are all, as I know many, many people are in the health world, just worn thinner.
So I'm just going to pick up, Bonnie, on one of your comments earlier. You talked about nuance creating fear. And to me, this feeds right into the comments that Stephen was making about having certainty, and it also is sort of the subject of one of the questions from the audience. Is there an opportunity to change our approach to better respond to early weak signals rather than waiting for the certainty to act? And any scientist likes to have certainty before they act, and this is, to me, a kind of crux of one of the issues in public health. So just, there is no wrong or right answer to this, but Bonnie, if you'd like to maybe comment on that.
Absolutely. We have to make decisions in the face of unrelenting uncertainty. And that is a reality of dealing with a crisis. in particular. And we do it day by day, but normally we like to take our time, we like to look at both perspectives and really understand before we make a decision to go forward with something. But not making a decision in a crisis has implications as well. So we do have to make decisions with imperfect information. And sometimes as a scientist or people with who are working on a specific project and have a very sometimes narrow but a deep view of one specific thing, the decision we make may not make sense to them. And for the many researchers out there, your field in great depth, but it may just be one piece of a decision that we have to make that involves a whole lot of other pieces, including those pieces that are less tangible, like if we change if we change a direction right now, will we lose trust because people don't understand what's behind it, or it's complicated to explain what's behind it? And we've seen a couple of things in the last little while where mixed messages lead to a lot of anxiety and fear and anger. So we have to be really careful with that, but it is a skill set to be able to make decisions with imperfect and changing information. And I've said many times, the tightrope that myself and my colleagues are on is you're always doing too much or not enough. And there are some times where it's more important to do too much, and there are some times when it's more important to do not quite enough. But you can never get it just right. And the ethical principles that we want is to do just enough. But it's really hard to find just enough.
One thing, Tony, I'll add, if I may, is I think in principle it sounds great, this idea of reacting, or maybe even like taking a precautionary approach, acting on weak signals. The challenge, though, is there's lots of weak signals out there, and we might find ourselves reacting every day of the year. I guess because I'm an international lawyer and an epidemiologist, so when I get asked a lot of questions about travel restrictions, border closures and such. And a lot of questions I've had is, well, why didn't the second that this was alerted to the World Health Organization on January 2nd, 2020, why didn't Canada just shut its border then? And the reality is there's something like 200 events every year that have a potential to become a pandemic. Should Canada, for example, be closing its border 200 times a year? Obviously, that's not practical. And of course, I'm not rejecting the idea of looking at weak signals. We have to have really strategic conversations and figure out which ones do you act on, what are thresholds and such, bring a science to bear on when do you respond. I think though what you've seen in this context of this pandemic is it was based on new signals. There was an uptick in the response, and there were certain triggers of things once additional information became known. But with the benefit now of looking behind us, what's clear is that sometimes the information that was available that triggered an action, the full effect of that action might not have been able to be achieved because it came later than what a trigger would possibly have allowed for that action to take place in the first place. By that, what I mean is, of course, maybe in this case, there are different actions that, for example, Canada or provinces could have taken earlier on, but they wouldn't have known that those were appropriate actions. You only get that with the benefit of hindsight. So it's people like, Dr. Henry, Dr. Ryan, having to integrate all of these things in terms of advice, so it can become, it's essentially an impossible task, because I guess neither of you have your crystal balls, but maybe for the next pandemic.
Yeah, but also I think in that, and I think it's right, what you decide today based on the data you have today is almost certainly wrong based on the data you collect today, tomorrow. So that's part of the game, and we have to be accountable for those decisions. There is, though, a paralyzing fear that people always fear the retrospective, right? The respect of what I say today will be used out of context against me tomorrow or the next day or in a year's time or 2 years' time. So people tend to edit their speaking, not for now, but for the future. And that is not always a good thing. That self-editing that goes on at times from one direction or the other, being more or less extreme than one could or should be. The other thing is, I think, is there's a tremendous amount, and this is where the interaction between science and public health and government and governance, in that you have a lot of people chasing unicorns and silver bullets and the thing that's going to work. What we need is a solution. Unfortunately, in public health, there is no such thing as a solution. There are many solutions within a complex, changing situation in which your advice and the science will change, the nuances will change, the combination of measures will change, the intensity of measures you need to use will change. And therefore, you've seen countries who've done well in this pandemic were very often the ones who, and no two countries who've done well have done the same thing. But what they all have done is done everything. What they've done is really looked at their public health and their surveillance and their community engagement, their health system. And countries that have tended to get through this better than others have been ones who didn't chase so many unicorns, looking for single solutions, single answers, single reasons for why it's happening, people to blame, looking for someone else to blame. They got on with trying to contain and suppress the virus and try and keep that virus suppressed at the highest possible level for as long as possible. That's been a success in many ways, but it also shows you just how fragile it is. And you've seen in countries, once they got control, now with some countries opening up on mobility increasing, the virus comes back. The virus doesn't get tired. We get tired. That's the problem. So I do think we need to be brave in public health and call it like it is. But we live in a world that is entirely unforgiving now, because you can't, Bonnie, stand up tomorrow and say, well, what I meant yesterday was, because you're immediately asked, so Dr. Henry, you said 14 weeks ago that this virus was this or was that. So how do you feel now that it has emerged that this is different now? And you think, well, it is different now, and that's good to know because we've changed our advice. But surely you must regret the advice you gave 14 weeks ago. I have been confronted with that type of question, and you think, okay, you cannot answer that. And I think that puts fear into public policymakers. And you end up with too many spin doctors then between the scientist and public health person and the actual communication with people, because everyone is managing the risk of what you're about to say. And I don't believe that's healthy. I really don't. We need an honest, direct communication between science and public health and communities with the least possible involvement of government, right? In that sense. And that is not easy in the current environment, right? Because it's a challenge. It's a real challenge. And we've seen these tensions emerge. There have been governments who've been really good. They've really given the floor to the scientists. They've let public policy, they make the policy, but they're very clear in saying, this is how we base our policy. Here's the science, and here's what we're going to do. And what we're going to do isn't always exactly the same as the science, because there are things to consider. There are issues to consider that are societal, economic, other issues, political, whatever it may be. And science doesn't always equal the policy that emerges, but it needs to be done transparently, where governments recognize and acknowledge the science, and then they add policy, and the policy then reflects the broader societal concerns that we'll have to maybe adapt policies as they're made. And I think we have to be honest with people. That's how the sausages are made, and trying to turn this into a perfect thing, a once-off thing, just doesn't work. And I think people get that, and they will accept that. But I do think, Bonnie, I don't know your experience, but certainly been held to account for a statement made 5 months ago, because new data emerges to prove that position needed to change. All that says to me is fantastic. We can now change that position to a better one because science is now giving us new information. But that's not the conversation we end up having. The conversation we end up having is, don't you regret giving that advice 5 months ago? And this is not very helpful. And I think it also creates a very bad mood music, because if those questions are being constantly raised with public health and science people, what happens is, I think communities begin to lose confidence and they begin to question themselves. And then you lose it entirely. I have no problem with people having to go at me. I don't mind that. What I have a problem with is communities losing confidence in the process, It's like the parents watching the children watching the parents fight. You know, neither parent comes out of that too well, because all that happens is kids lose trust in both parents, not in that. And I think that's a factor here. And I think there's been a lot of negative scientific discourse. And for the first time, Tony, Stephen, and Bonnie, I have seen scientists being ideologic, taking ideologic positions, being super activists in areas. And I've never seen that before. I really have not seen that before. Ideologic science. I've seen ideologic politics, but ideologic science I have rarely witnessed. And it has been a huge part of this response. And I don't know if you have been, but we have been attacked so many times. And I can tell you, attacked by fellow scientists, you know, and that has been really hard to take, really, really hard to take. So I do think that we need to be very careful how we use words, you know, in this whole process. But we also need to be brave.
I am right with you there, Mike, and it is true. You know, if people parse everything we say and interpret it in their own way, which is human nature, but it's very difficult when our own colleagues are on different poles and saying different things and questioning in the media or in the public how we are making decisions. And you know, calling decisions that we make using the best information we have a grand experiment on the public, and trying to put it out there that science in action means that we do need to change things. And yes, people get very angry at me and you know, have been threatening, and others have had this same thing too, because in a crisis, that sense of vulnerability leads some people to lash out in anger, and our colleagues in healthcare and science are no different. So we need to have that forum where you can vent all those concerns, but then have a united front around how we move forward and talk to people about what the reality is and what we know and what we don't know. But it's hard. It's very hard, and it's relentless because it's been going on for so long.
Yeah, no, it is true. And I'm 30 years working in this space, and I've been a hostage. I've been so many other things. I've never had anyone directly threaten my life. And I've had that this time in this response. And I have worked in every crazy place you can imagine. And yet I had to wait for a pandemic of COVID-19 to have our lives directly threatened in a constant and vicious manner. It's been very, very tough for us all to maintain decorum and maintain, you know, our own mental health in the face of these attacks. But I think we've tried, all public health practitioners around the world, and Stephen and people in research, we've all tried our best. We've not been perfect. We've certainly not been perfect. And there's so much we can improve for the future. But I think everyone who's worked on this has given their best. They've tried their best. They've tried to use every skill, every capacity, every bit of knowledge we've had. And we've, you know, but that obviously hasn't been good enough. And we all need to go back to the drawing board. So this isn't about blaming others and saying, well, more money will fix the problem and governments are at fault. I think it's time for us all to stand back and reflect on how we have or haven't served our communities, and to reflect on how we can all get better at what we do every day. All I know, that's what I do every day. I'm sure you do it too, Bonnie and Stephen and Tony. Just get up every day and try to do better than you did yesterday. I'll keep doing that. But the pandemic has shown a slightly more sinister side of the way this business gets done. Something that's disappointed me personally, the way it's become personalized at some times. But anyway, that's life. We get on with it and we'll persevere. And
you know, for the audience there, I know there are many students, many people who are doing research. This is just to say your piece is important and it means a lot, and we hear it, and we need to make sure that we can use the right words to put that into the context that we need to share with the world. So sometimes I know people tell me that, oh, you're not listening to me. I told you this was going to happen. My research said this. and just know that, yes, I am listening, and we have a very good system of bringing that into our awareness and our understanding in Canada and in BC, but it doesn't always mean that we act the way you think we should, because there are so many other factors that need to be in there as well. And the one thing that I really hope that we get out of this, and GenomeBC, and I've been talking with them about this, is how do we build those communities where we can have those discussions in a safe way, so that we are presenting a message to the public that is understandable and that is changing as we gain more knowledge, because words matter and it is important.
Yeah, and I hope I wasn't seen to be shutting that down. We need activism. We need more activism from young people in particular, and we need people to be disruptive. The system needs to be disrupted in many ways, but we need people to be constructively disruptive. We need people to engage, express their opinions, say what's wrong, but also suggest and present solutions. We need to have a better dialogue, not just a shouting match. We need a better dialogue with our communities around our values, around the culture of healthcare and healthcare delivery, around dignity, around access, and around making the system better. And I think if we do that, we will make progress. But we do need activism, and we do need disruptors. Nothing ever changes unless it's disrupted. If you change nothing, nothing changes. So we do need change, but we need to do that in a way that we go forward together, and not separately. I have to leave, Tony, so I'm going to leave you to these wonderful people, and with my great respect to everybody in Canada. And again, thank you to all Canadians for not only the work that's done in Canada, but for the wonderful work that Canada does abroad. Both governments, NGOs, and people, Canadians, are all over the world responding to this pandemic and so many other humanitarian crises. With my deep respect for all that Canada does around the world. And I'll say goodbye to you here.
Mike, thanks very much for your time. It's been a pleasure, and I appreciate all the work that you're doing at the WHO. It's great to see you guys in action and to learn your perspectives and to learn about what you're doing. So thank you very much. We're going to carry on now, and I'm going to pick up on a question that's more provincial, if you like. There was a question to you, Bonnie, about there's been a bit of a strategy lately in BC of reducing genome sequencing. And I just wonder if you'd like to comment on how that impacts public health measures and how you respond to variants.
Yeah, you know what? I think this is also a complex thing that has been misinterpreted. We are not reducing whole genome sequencing. As a matter of fact, we've stepped it up. What we're doing is trying to, instead of doing it piecemeal, which was what was happening, be more systematic so that we actually can detect the next change that will make a difference, the next concerning variant. So we are doing more genome sequencing than I think any other province and many other countries. And we've got tens of thousands of sequences that we are following, but we're targeting right now. So we're only doing a percentage of the positive cases every day. We're doing a random sample of those so that we can understand better what proportion are different variants of concern, for example. And mostly it's B117 and the P1. But we're also doing very select things where everybody who's a breakthrough case, who's been immunized, we're doing whole genome sequencing to understand if there's something new or different that we need to be aware of. We're monitoring outbreaks, so we're doing whole genome sequencing to help us understand outbreaks, and that's something we've been doing since the very beginning. It helps us understand how viruses are being transmitted in schools, for example, and that's been really helpful in some of the long-term care outbreaks, especially now some of the long-term care outbreaks in the very highly immunized populations. So we have been targeting so that you're not just playing whack-a-mole trying to say, oh, well, there's one here and there's one there. And we have to remember again what I said from the very beginning. These are not variants of concern. These are people who are infected with a virus. And we use tools like the screening testing and whole genome sequencing to understand if those viruses are behaving differently or make us need to change our approach to what we're doing in terms of public health measures, the contact tracing, isolation of people, and to help us understand if our vaccine program is still working well. So the P1 is a good example. We had people who traveled to the province. We had spread of that virus from people in communities like Whistler, for example, where we had quite a lot of spread, and it happened to be with a variant that had been introduced, and it spread between people. Now that we've taken measures in that community to isolate people who are sick, to prevent transmission, and to immunize. And so we're seeing that come down nicely. So we are not stopping or changing or reducing whole genome sequencing. We're using it in a way that helps us better understand what we're seeing in terms of virus and virus transmission in the province.
Thanks, Bonnie. And then just one more question. So various jurisdictions around the world have sort of, and we are in BC, sort of pursuing a bit of a mitigation strategy, except some evidence suggests that maybe an elimination strategy is a superior one. Do you agree with that, or and what are the sort of takeaways from that kind of thinking?
And maybe I'll ask Steve to talk to that too. But words matter, and what people are defining as an elimination strategy versus the reality is that this virus transmits between people. And when it is in communities, transmitting in communities at a level where there's a lot of ongoing transmission, and we reached that level a year ago. We are learning that you cannot push this virus back into nature if you live in a connected community. So yes, if you live on a small island in the middle of the Pacific, or where my family lives in Prince Edward Island, where you have one bridge and one way in, you can do your best at suppressing the virus. But even then, and we're seeing that in Nova Scotia, we're seeing that with transmission that we see in Prince Edward Island and in New Zealand, you cannot stop people from interacting with people. And unless we wrap everybody in bubble wrap, we can't stop people from having those social connections, those interactions that we need. So we are doing our best to reduce this. And and I believe that we are taking an approach that is going to allow us to protect those people who are going to have the most adverse events or adverse outcomes from this virus. And we will reach a point where it will be a respiratory virus like we have every year with influenza, where we've got it down to a level in our community where it doesn't disrupt our lives anymore. So we're out of the pandemic, but we still need to live with it. And we're going to have to live with it in some way or the other for the next number of years. What we need to do is make sure that we're protecting people who are in communal settings, who are most likely to have severe illness, and relying on the work that we do in public health, like we do with other transmissible viruses, to stop outbreaks, to detect outbreaks, to manage people, to make sure immunization and protection is kept up. So, I see this transitioning from the pandemic to another respiratory virus that we need to pay attention to every year. I don't know, Stephen, if you have ideas on that too.
Yeah, thank you. I agree with everything that you said, but also just to highlight, it's not as, of course, as you just mentioned, it's not as simple as just choosing one strategy or another. Some countries have certain features about them that give them certain strategies that are available to them, others that are not as easily available. And so, I think a lot of us, for example, reading the newspapers, a lot of us would be thinking about New Zealand. But New Zealand has physical geographic features, namely that it is, for example, a 4-hour flight from Australia, 20-hour flight from the Americas. That means that certain strategies that might be available to New Zealand would not be available to Canada. Geographically, one of the largest countries, one of the longest undefended borders in the world, the longest undefended border in the world, for example. And so I think what's really important then is figuring out, it's not about choosing which of two strategies, for example, would be best for the world. It's really about, given a country's circumstances, given a province's circumstances, a city's circumstances, what is the right strategy for that community? And it's not as crystal clear as being able to say one strategy is overall best. Although in this pandemic, we've certainly learned a lot about the various different strategies available to different jurisdictions and which ones might be more effective than others. And that will be really important to take forward into future emergencies of various kinds.
Thank you. So I would just like to wrap up by saying that thank you both for some fantastic insights. Thank you to Mike, even though he's not here, for his fantastic perspective from the WHO. Thank you to the audience very much for persevering with us through some technical difficulties. Hopefully they will be sorted out by the next session with Zoom. Once again, on behalf of the audience and behalf of everybody at GenomeBC, thank you very much to Dr. Bonnie Henry and Dr. Stephen Hoffman for some wonderful insights today. Thank you and have a good day.